I'm Allison Mondragon. I'm an OB instructor here at Cal State San Marcos and a women's health nurse practitioner. Today I'm going to be showing you how to do a postpartum assessment. Postpartum assessment follows the acronym BUBBLE, HE, so we will be doing a postpartum assessment from head to toe. OB is a very family-oriented place, so you can actually find out a lot about how your patient is doing just by looking around the room. Is their family present? Is the significant other present? Are they involved in the care of her and her baby? How's the mom doing? Is she bonding with her baby well? Part of your postpartum assessment is an emotional assessment, so you don't want to make that determination at the end of your assessment. Find out what else is happening as you go along with your assessment. As you know, you always want a hand hygiene when you come into the room. Introduce yourself, identify your patient, explain what's going to be happening, that you are doing a postpartum assessment. You are going to be pushing on her abdomen, which can be very painful for her. So the first thing you want to do is find out what her pain level is. If she needs pain medication, medicate her before you do your assessment and wait for the pain medication to work before you start your assessment. The other thing is you're going to be assessing her bladder as well. So you want to ask her when the last time was that she emptied her bladder and when the last time was that she changed her pad. That will give you a baseline for how much bleeding she might have. Make sure you provide privacy as well. A lot of times, especially moms that have just had babies, have no modesty whatsoever. All their modesty's been taken away inside the hospital. So make sure that she has privacy. If there's family present, ask them if they would like to stay. Ask the patient if it's okay for people to stay in the room. Otherwise, ask everyone to step out and you'll be with them shortly. So you want to have a very quick listen to her heart and her lungs. That's not the primary focus of your assessment, but you want to make sure that her lungs are clear and her heart has a regular rhythm. Also, listen on her abdomen for bowel sounds before you actually start palpating her abdomen. Her abdomen should be soft and she should have bowel sounds in all 4 quadrants. So the first portion of your postpartum assessment is the breast exam. So it's a breast assessment. It's not actually a breast exam. It's not a self-breast exam. You're not teaching her how to do that. So after you have listened to the heart and the lungs, you listen for bowel sounds. Expose one breast at a time. And what you're looking for is any abnormality in the tissue. So lumps, bumps, anything that looks unusual. If breastfeeding is not going well, this is usually where you will see the evidence, is in the nipple area. You may see some tissue breakdown, you may see some redness, some chafing. All that is usually because the baby does not have a correct latch and you need to correct the underlying problem, which is the problem breastfeeding, before that's going to get better. Expressing some of her own colostrum or mature milk will actually help the tissue heal, along with lanolin cream or ointment. You start up here and just go around in a circular motion, just feeling for any lumps or bumps, anything unusual. And you're talking to her as you're doing this about the process of lactation. So it's actually the decreasing amounts of estrogen and the increasing amounts of prolactin after delivery that start the whole process of lactation. She actually makes colostrum in her 2nd trimester of pregnancy. So it's already there waiting. It's just the levels of hormones that need to change. Mature milk, which is what we like to call it now, we don't say milk coming in, because then it makes it sound like she doesn't have anything until her milk comes in, but she does. Colostrum is very, very beneficial to a newborn's gut. It's a natural laxative, helps the stool move out, but also has lots of benefits to baby and mother as well. Then you want to expose the other side. And while you're doing this, you're also kind of noting whether the breasts are asymmetrical, which is not unusual. Some women have asymmetrical breasts. That is usually not in itself unusual. You complete both breast exams or assessments. This is also a good time to talk to her about the difference between engorgement and mastitis. Mastitis is an inflammatory type of problem, so it's not something that's going to be seen in the hospital. It takes time for that to happen. The most common reason for mastitis is the baby is not feeding well. Milk stays in the breast and starts growing bacteria, and that's what causes the infection. So mastitis is very painful. It's usually in the outer aspect of the breast in sort of a pie shape. Redness, warmth, pain, swelling, and again, it usually is going to happen as a result of breastfeeding not going well. Engorgement, on the other hand, is an overfilling of the breast. So it is a combination of edema and a vascular issue. So engorgement, the way to make sure that the patient doesn't have engorgement is early, frequent feeding, breastfeeding. So put the baby to the breast as soon as possible after delivery, and then look at the baby's cues. Every time the baby has feeding cues, you put the baby to breast, and you talk to the mother about cluster feeding. Cluster feeding is feeding in clusters, and that's what babies do. That's what newborn babies do. So they'll feed a little bit, they'll take a nap, they'll wake up, they'll be hungry again, just within 15-20 minutes. So it's a lot of very frequent suckling, and that is what actually phones in the order for milk within a few days. So the more the baby is very frequently suckling initially, the more milk she will have when her mature milk comes in. So the way we treat engorgement, if she does happen to get engorged, is warm compresses, ice, cabbage leaves are actually very helpful, and Motrin, a nonsteroidal anti-inflammatory that is totally fine breastfeeding. The next portion of your assessment is the uterine assessment. You want to make sure that the patient is lying flat for this assessment. Otherwise, you are not going to feel the uterus the way you should feel it. So you're assessing the fundus, which is the top portion of the uterus. The uterus should be involuting, or going back to its pre-pregnant state, 1 to 2 centimeters every 24 to 48 hours. And we measure that in finger breaths. So it's usually, if she's a day postpartum, it's usually going to be right around the umbilicus, or at U is how we say that. You want to make sure that the uterus is supported. It's suspended inside the abdomen with ligaments that have been stretched, and they haven't gone back to their pre-pregnant state yet. So the uterus is just kind of in there flopping around. So you want to make sure that you have support down right above the pubic bone with your hand cupped. And with your other hand, you're coming down from the xiphoid process with this side of your hand. And you're coming down, palpating in pretty deeply until you feel something that feels firm, kind of like a ledge. The uterus should feel like a softball at that point. If you can't feel it, or it's boggy, if it is boggy, it needs to be massaged so that it will start contracting. The uterus is nothing more than a big muscle. If you can't feel it, it's because you aren't palpating deep enough, or the bladder is full and has pushed the uterus off over to the side. And in doing that, the uterus can't contract, and that makes her at a risk for bleeding. So it's either 1 or 2 below U while they are in the hospital. And women that have had a cesarean section, your hand is actually right over where the C-section incision is. So make sure you're not really pressing down firm. You just have your hand kind of cupped over that area. The uterus also should not be tender. If the uterus itself is tender, then that usually is indicative of infection. The bladder is directly on top of the uterus, so it's very uncomfortable to try to find her fundus if her bladder is full. So again, make sure that you have asked when the last time was the patient emptied her bladder. We give liters of fluid to women that are laboring, so we want to make sure that she's able to use the restroom and she's getting rid of the same amount of fluid that we have put in. So the first couple of voids are actually measured in a hat that's in the restroom, and it's put underneath the toilet seat. We usually measure the first 2 voids that need to be at least 150 cc's per void. So you want to make sure also that you talk to her at this time about hygiene. There is a little peri bottle, it's a squirt bottle, very similar to what actually happens with a sitz bath. So it's filled with warm water, and every time she uses the restroom, she should squirt the warm water on the area. That not only keeps the area clean, but if she has any repair, which we'll talk about a little bit later on, if she has any repair, it helps in the healing of the repair. The next part of the assessment is bowel. So you've listened to her bowel sounds. Her abdomen still has a pregnant look. The linea nigra, which is the line up the abdomen, is still very prominent. That takes time to fade. You ask her when her last bowel movement was. It's not unusual to not have a bowel movement for 3 to 5 days after a delivery. A lot of times their appetite is very decreased before they have a baby, so there isn't really a lot in the bowel. And the hormones of pregnancy actually slow down the bowel, so it's not unusual to not have a bowel movement for 3 to 5 days. If she does have trouble with constipation, you want to make sure that you talk to her about her diet, high in fiber, lots and lots of water. Sometimes medications like narcotics can cause constipation. Make sure that she's aware of that. Colace is a stool softener that is very, very common medication in OB. And if she needs something stronger like a laxative, that usually can be ordered by her provider as well. If she has hemorrhoids, we can assess those when we turn her. But also the underlying problem with hemorrhoids is constipation. So make sure that you talk to her about her diet and not straining when she does have a bowel movement. That tends to make the hemorrhoids worse, just sends more blood supply to the hemorrhoids. After you have done your assessment on the uterus, the bladder, and the bowel, you want to make sure you turn your patient to the side, ask for her help, and turn her away from you. This is really important because you can have very little bleeding on the pad and they can pool underneath them, and you actually will not see a lot of bleeding until you turn them on their side. As you turn them on their side, then you can assess the episiotomy. It's much easier to assess the episiotomy and actually what it looks like having the patient turned on their side away from you rather than looking in, trying to see the episiotomy, which is the tissue. It's a cut in between the tissue, in between the vagina and the rectal area. It's much easier to see if you can turn her on the side and then just lift the buttock cheek. Lochia is just another way to talk about her vaginal discharge or the type of bleeding that she has. So initially in the hospital, she has what's called rubra. That's bright red bleeding. My definition of heavy bleeding is soaking more than a pad an hour. Ideally, her lochia should turn different colors as time goes on, and it should get less and less every day. If it doesn't, then she needs to let her provider know. But it does start off as what we call rubra, and that's generally what you see in the hospital setting. Then it changes to serosa, which is more like serum, so it's a pinky yellow kind of color, and then eventually goes on to alba. It's really not that important to know the amount of days that it takes for that to happen. It's more important to let the patient know that there should be a definite change in color and the amount from day to day. If she transitions from rubra to serosa when she's home and then it goes back to rubra, that's a problem. That means that the uterus is not contracting like it needs to. It's not involuting like it needs to, and she needs to let her provider know. Menstrual periods return at different rates. If a woman is breastfeeding, she may not have a menstrual cycle, but generally, once she goes through the 3 different colors of lochia and then goes back to bright red, that's considered a period. An episiotomy is a cut in the perineal tissue, and that's usually made to make the opening bigger for the baby's head. That's repaired with dissolvable suture, And just like any other wound, you want to make sure that she keeps that area clean and dry. So again, the peri-bottle is very important. Also, if she tore, lacerations are repaired in the same way with dissolvable suture. It usually takes about 2 weeks for the sutures to dissolve. And in the meantime, she uses her peri-bottle every time she uses the restroom. Tux pads, or witch hazel pads, are helpful with the irritation. Make sure that she's medicated for pain as well. You can also notice if she has any swelling. If the woman does a lot of pushing during labor, you can have pretty significant labial swelling, and ice is helpful for up to 48 hours. So make sure that she has that for comfort as well. This is also the time to talk to her about kind of revisiting hygiene. One thing is no intercourse for 5 to 6 weeks. And that is because the vagina and the cervix are actually very vascular. You can have little micro tears in the tissue, and you can have infection that sets in. So you need to wait until the tissue is totally healed before she initiates intercourse again. If she's breastfeeding, the return to intercourse can be on the dry side, and you can suggest a water-based lubricant at that point because she doesn't have the estrogen that makes the tissue more moist. Next step is Holman's sign. So DVT is very common in pregnancy and also postpartum. That's due to elevated levels of clotting factor and also elevated estrogen levels. So it continues to be a problem all through her postpartum time period. Now, Holman's sign is not in itself indicative of DVT, but it is one of your assessment tools. So to correctly assess Holman's sign, you can either support the back part of the knee and ask her to dorsiflex, or you can leave her flat on the bed and just ask her to dorsiflex. If she has pain in her calf and it's unilateral, it could be a DVT. If she complains of pain in both calves, that's muscular. That means that she was up in stirrups for a very long time period having her baby. DVTs are unilateral. The other things to look for in a DVT are redness, warmth, swelling, and pain. So if you assess for any of that in the calf area, you want to let the provider know, because at that point a Doppler study is the gold standard for determining whether she has a DVT or not. DVTs are treated with heparin in the hospital, and then they're discharged on Coumadin, and Coumadin is totally fine breastfeeding. Any of the medications I've talked about so far, such as Motrin and narcotics, are totally fine breastfeeding. The amount of medication that gets to the baby is very, very small amount. It's actually more important that the woman breastfeeds, more important for her health and also more important for the baby's health. The other thing that you want to assess while you are assessing her lower extremities is edema. So edema is very common, dependent edema is very common in pregnancy. She has 1,500 cc's of extra fluid that her cardiovascular system is pumping around, and it tends to pool in the lower extremities. So you want to assess the amount of edema and the amount of pitting edema, the degree of pitting, if she does have pitting edema. Sometimes it can extend all the way up the tibia as well. You also want to palpate your pulses, pedal pulse especially, and make sure that her toes are mobile and everything is warm. The other thing to remember about edema is to let the patient know if she does have a lot of edema, it can take 2 to 3 months for that edema to resolve. Her cardiovascular system takes sometimes up to 12 weeks to get back to its normal pre-pregnant state. So that is not unusual. She can elevate her feet, decrease the salt in her diet. That will help as well. Compression stockings, if she has that, that's helpful as well. Then the last portion of your assessment is emotional. So while you have been doing your postpartum assessment, you're talking with her and finding out how things are going for her. Is this her first baby? Does she have 3 other children at home? Does she have any family in the area? Sometimes Women will have a lot of risk factors for postpartum depression, such as a previous history of postpartum depression or any sort of mental illness herself, mental illness in her family. Those are all risk factors. If she's alone, if she's a teenager, those are all risk factors. It's important to talk to the patient and the family about how common postpartum depression is, so that she doesn't feel, if she does get depressed, like she's all alone. Postpartum depression actually is much more common than we think it is, higher than 15 to 20% most of the time. And postpartum depression almost always needs counseling, medication, or both. And that's very important to let the patient know as well. The difference between baby blues and postpartum depression is the amount of time that the woman has had the symptoms and the severity of her symptoms. If she doesn't feel like caring for herself, she doesn't feel like caring for her baby, she's isolated socially, she doesn't feel like going out, all those are really big red flags for postpartum depression. Most of your medications, including the SSRIs, are fine breastfeeding, and it's actually more important that she gets her treatment. Breastfeeding, we have found, is actually very important in the whole process as well. It really helps with the bonding as well. So we don't want to discourage her from breastfeeding just because she may need medication for postpartum depression. And again, counseling is usually something that's offered along with medications. It doesn't mean that she'll need to stay on medication forever, but at least 6 months of medication is what is currently recommended. The last thing is to make sure that she is aware of when she needs to follow up. 2 weeks for cesarean sections usually, then again at 6 weeks, and a vaginal delivery usually at 6 weeks. This is why it's so important to talk to your patient and the family about postpartum depression and some of the other things that may happen, like mastitis, which is a breast infection, will definitely happen before she goes back for her 6-week check. Make sure if she has any of those symptoms that she gets in touch with her provider. Also make sure she has a provider for her baby as well, a pediatrician. Generally babies are seen within the first few days. If she has any trouble with breastfeeding, there's usually resources in the area where she can get help with breastfeeding as well. And the last thing you want to do once you've finished your assessment is to make sure that the bed is down, and make sure that the head of the bed is raised so that she's comfortable. Make sure that her call bell is within reach, and thank her for being able to do your assessment. Remove your gloves, hand hygiene, and document, and exit your room.